So welcome everybody. This is my Brachial Plexus MRI lecture, and this is going to cover our current Brachial Plexus MRI protocol, the rationale behind each of the sequences that we have chosen, and the discussion of pathologies that affect the brachial plexus, which we often receive requests to be imaged. I'm going to go through the methodology I use to look through the scans in each case, and we'll finish with a few examples of pathology. Now, as we all know, the brachial plexus is made up of the ventral nerve roots from C5 through T1, and these are coalesced into the superior or upper, middle and inferior trunks, which give off divisions which then rejoin into the lateral, medial and posterior cords, which then give off the terminal nerves. When we are talking about brachial plexus imaging, we are mostly referring to the nerve roots, trunks and cords, and this is because most of the smaller terminal nerves are not visible on our current sequences. Certain nerves are visible on high-resolution 3 Tesla imaging with custom planes, and the long thoracic nerve, for example, has been demonstrated in certain studies, but for all intents and purposes, these aren't visible on standard brachial plexus imaging, and the only nerve that is really visible to a consistent degree is the suprascapular nerve, as is seen on this coronal MIP study. This is useful as it is one that is often involved in pathology. The terminal nerves in the upper arm and axilla are usually not visible either, as we do not do dedicated axials through the upper arm, but if needed, these can be added on. On the sagittal images, which are the easiest to interpret in terms of distinguishing the individual brachial plexus structures and determining pathology, the C5 through T1 nerve roots are easily distinguished with the first rib in between the C8 and T1 roots in this parasagittal image. This second image is taken just slightly distally in the interscalene groove, where you can see the roots starting to coalesce into the trunks on top of rib 1, in between the anterior and the middle scalenes. If we go further lateral, we're now in the infraclavicular space, and the first rib is now elongated slightly to become the floor. And you can see that the C5 and 6 have coalesced into the upper trunk, and C8 and T1 into the lower trunk. Further distally, we see the cords in the typical position on top of the subclavian artery, with the posterior cord in the middle, and the medial cord posteriorly and lateral anteriorly. When it comes to indications for brachial plexus imaging, the most common indications I receive fall into 6 categories. The first and most common is trauma, and this is usually from A&E or plastics. And the question in these settings is usually between preganglionic or postganglionic injury, and whether the injury is low or high grade, because the patient has presented with weakness after an injury. The second most common is malignancy or post-malignancy, and whether there is any malignant infiltration of the plexus, and whether this is related to previous radiotherapy or not. These are not always easy pathologies to distinguish, and we will go through this on a later slide. The most common routine indications that we get referrals for are either painful unilateral shoulder girdle pain, and this is usually querying brachial plexitis, and query thoracic outlet syndrome, which, as you know, is a slightly controversial topic. And I will go through what I understand about the topic currently and the positive case that we have had in the trust on a later slide. The last 2 indications are the more ephemeral requests. We sometimes get a request from neurology that there is a peripheral neuropathy of some kind, but nerve construction studies either do not correlate with clinical findings or they suggest a plexus injury directly. And in this case, we are really just looking for something odd in the brachial plexus causing symptoms. It's usually normal, but on the odd chance, it might be a tumour, some kind of malignant infiltration or a nerve sheath abnormality. We've also been getting increasing requests for brachial plexus from GPs, usually in just slightly puzzling cases of shoulder and arm pain, and these are inevitably unremarkable. This is a depiction of the current MRI protocol, and it's a result of trials of different sequences on the GE machines that we have in the trust. We have gone for the 3D coronal imaging to be done as a Dixon, because the Dixon has better signal-to-noise ratio than the STIR on the GE machines. We then do the hypercube STIR and structural T1 sequences sagittally, which allows assessment of the nerve signal in the plane in which the nerves are best depicted. In patients with a query of malignant infiltration in the setting of known malignancy, we may also do post-contrast imaging. And if there is a strong suspicion of thoracic outlet obstruction, we may also do arms up and arms down sequences, but patients often don't do very well with these due to the length of the overall scan, and as such we usually save these for patients in which the clinical suspicion is strong. Next, we should discuss nerve injury. As you know, the most common classification of nerve injury uses the Sunderland classification, and these basically correspond to the different nerve layers, and injury to each of these in turn. What the surgeons are going to want from us is to differentiate the lower grades of nerve injury, in which case there will be recovery and is likely not to require a surgical outcome. In this case, the perineurium and epineurium remain intact, and as such the nerves regrow along the course of the fascicles, and there is no chance of a neuroma in continuity. In contrast, high-grade nerve injuries, where there is disruption of the outer nerve layers, you may expect nerves will not regrow in the correct direction, and you will either get a neuroma in continuity, or in worst-case scenarios, complete separation, retraction, and end neuroma formation. And these generally need surgical intervention, either with nerve transposition or tendon transfer. In trauma, we are talking either about direct trauma, i.e. context of first rib fracture, or arm traction type trauma with weakness. And what the surgeons want to know from us is a distinguishing of pre- and post-ganglionic injury, or whether the injury is mixed, as in traction trauma. In the period of time within 2 weeks of injury, you will probably only see hematoma in most cases, and plastics may ask for it to see if there is hematoma compressing the plexus. I don't have any real clue as to how to tell whether a hematoma is compressing the plexus or not, but you can just report as you see. Usually the area just looks like a bit of a mess on imaging, and the plexus structures cannot be distinguished from the hematoma. If there's persistent weakness and they are still uncertain as to what nerve has been injured, then they will come back for repeat imaging after 6 weeks. And in this case, we are looking for postganglionic or preganglionic injuries, i.e. neuromas in continuity, or end neuromas, or avulsion of the rootlets. As you can see in this case, I have borrowed. It's important to note, as in this case, that root avulsions do not always exhibit pseudomeningoceles, and as such, these are not a reliable indicator of injury. The way I look at trauma sequences is to first look at the T2 cube sequence in order to see the cervical nerve rootlets and see that they are still connected to the spinal cord. Preganglionic injuries usually avulse these rootlets from the spinal cord, and you will either not see the rootlet, or the spinal cord may be displaced to one side or display distortion. I then turn to the coronal Dixon image to look at the nerve signal in the plexus, and it's often better to use the maximum intensity projection. I usually use a 9mm thickness. And this allows you to appreciate the nerve signal side by side, comparing the left and right sides. I'll then put it back to the regular thin slice coronal image and look for denervation edema in the shoulder girdle or the paraspinal muscles, which will be looking for postganglionic or preganglionic injuries respectively. I next look at the sagittal stir image and correlate it with the T1 sagittal, so I can visualize each of the brachial plexus structures in turn, and have another look at the nerve signal and caliber, and whether the fat planes are preserved between the brachial plexus structures. Brachial plexitis, or Parsonage-Turner syndrome as it is sometimes known, is a kind of idiopathic inflammatory condition of the plexus, which is probably a post-viral type condition or autoimmune related. Clinically, there's a painful denervation of the shoulder girdle, and it's associated structurally with multicentric nerve constrictions. As you can see on the top right picture, which is an ultrasound of the suprascapular nerve and surgical correlation, the suprascapular nerve varied in caliber throughout on the ultrasound, and on the surgical exposure you can see 2 constrictions and the nerve was torted. Most common nerves affected by Parsonage-Turner syndrome are the nerves originating from the upper trunk and less commonly from the middle trunk. Mostly this represents the suprascapular nerve and the long thoracic nerve, but less commonly also the axillary nerve, musculocutaneous nerve, and phrenic nerve, with the lower trunk being much less commonly affected. And in this case, usually the anterior interosseous nerve is affected, with no other part of the median nerve affected. On MRI, you're specifically looking for the suprascapular nerve and whether it is of high signal and whether there are visible constrictions, as in this case. Bear in mind that 1/3 of cases are bilateral, although, as you know, classically in textbooks, it is a unilateral condition. More commonly, you can see denervation edema within the shoulder girdle, affecting the supraspinatus and infraspinatus muscles, and or the serratus anterior, if the long thoracic nerve is affected. In the case of malignancy, usually we are talking about patients who have had previous breast cancer or current breast cancer, or less commonly, head and neck malignancies, sometimes after a neck dissection. Sometimes we are looking at patients decades after their diagnosis, after they have been long cleared of cancer. In terms of people who are at risk of radiation plexitis, all patients who have received more than 60 grays to the plexus are at great risk, and the symptoms can occur years and sometimes decades after the radiotherapy. On MRI, plexitis due to radiation looks like soft tissue enlargement, which is smooth around the plexus. It can only affect one part or all of the plexus, but it usually favours the upper trunk due to the radiation beam. It's usually of low signal on all sequences, but in some cases can be intermediate on T2 weighted images, in which case it can mimic malignant infiltration. It often shows some enhancement on post-contrast sequences, but if it shows no enhancement, this can have some negative predictive value, and as such we do usually use post-contrast imaging in these cases. As you can see in this case, which is a case of breast cancer who was 10 years clear, the query was over a new weakness in the right arm, and you can see on the non-contrast T2 on the right side, there is abnormal enlargement of the lower trunk, which was relatively atypical for radiation plexitis. We did a pre and post contrast image, and as you can see, the lesion does not enhance. And as such, we were fairly confident that this was due to radiation plexitis, and there was no change on the follow-up imaging. However, malignant infiltration of the plexus can still be difficult to differentiate from radiation disease. It can be more mass-like and can have a higher T2 signal than radiation plexopathy. It tends to favour the lower trunk, as in our previous case, and sometimes, most helpfully, it can be contiguous with other known disease, for example in the lung apex, or any adjacent involved lymph nodes, and it always enhances to some degree. Here you can see, especially on the sagittal images, soft tissue encompassing the whole of the brachial plexus, with the subclavian artery shown as a signal void within. And in the lung apex, you can see a further small new metastasis. Thoracic outlet syndrome is the last and most controversial of the topics that I'm going to go through. And I know that most clinicians are very mixed on this topic, but this is what I understand from what I've read about it. In terms of the demographics of the patients that we are looking at, we're talking about patients who get arm symptoms when they abduct their shoulders. And this can be either pale fingers, in which case it's a vascular type thoracic outlet obstruction, tingling fingers and weakness, in which case it is a neurogenic type, or a mixed vascular and neurogenic symptoms type. The neurogenic type or neurogenic symptoms related to thoracic outlet obstruction usually occur in young women, and they can be associated with a structural abnormality in the thoracic outlet. I'm sure, as you know, the most well-known is the cervical rib, but you can also get elongated C7 transverse processes, in which case there is a fibrous band analogous to the cervical rib passing from the C7 transverse process to rib 1. And in the minority of cases, you may have an anomalous muscle, for example, a particularly wide and stiff middle scalene, or an accessory scalenus minimus, to name two. The result of all of this is that there is some kind of compression and or deviation of the lower trunk of the brachial plexus, and this lower trunk abnormality is what we are looking at on brachial plexus MRI. In most cases, the deviation of the lower trunk is greater in the arms up position, and the note has to be made that when I say arms up position, this is in the Aber position, not the Superman position. And in most cases, in the Superman position or in full abduction of the arms, Pressure on the brachial plexus is actually relieved, and you won't see any brachial plexus or vascular obstruction on MRI. In cases with a vascular component, you can also get compression of the subclavian vessels in the arms up position, and this is best seen and measured on ultrasound, as you can see on this case that I've taken from the literature. The top two images depict the ultrasound done in the arms down position, and as you can see, the subclavian artery shows normal arterial flow. In the arms up position, as seen on the lower two images, there is a pre-stenotic compression of the vessel, which you don't always see because sometimes patients may have the compression underneath the clavicle, which is obscured on ultrasound. However, you can see that the arterial flow changes to a tardus parvus type post-stenotic waveform, which is suggestive of significant stenosis. Other things you may see on ultrasound include venous thrombosis and other vascular abnormalities. And in some cases, patients with neurogenic thoracic outlet obstruction may show vascular thoracic outlet obstruction on ultrasound, even though they do not have vascular symptoms. On MRI in these cases, I first look at the C8 and T1 nerve roots. Normally these can be of high signal, but this should not persist into the lower trunk. Look for an enlarged C7 transverse process or cervical ribs. Sometimes these are difficult to see on MRI, but now we are using three-dimensional imaging. It is a lot easier to see on MRI than it was using our previous protocols. I then follow the C8 and T1 roots out on the parasagittal images into the lower trunk and look for deviation of the lower trunk on the sagittal images by a fibrous band or any change of position or shape between the arms up and arms down position, or if there's any specific reduction in the retroclavicular space. In this case from our trust, as you can see, the first image is just lateral of the interscalene groove. The C7 transverse process is still visible, which is unusual, and therefore it is elongated. The C8 and T1 roots are easily seen, and there is no abnormal signal of either. Further lateral, you can see that the C7 transverse process is still visible, and the lower trunk has formed, which is abnormally large compared to the middle and upper trunks. You can imagine there is probably a fibrous band running from the C7 transverse process down to the first rib and entrapping the lower trunk, although, as usual, this is very difficult to actively visualize this on the MRI due to the plane in which the fibrous band is running. On the next image, you can see that the transverse process is now gone, but the lower trunk is still abnormal in signal and enlarged. And on the last image, you can see that the lower trunk still has abnormal signal, but is the same size as the upper and middle trunks. And this patient had the same findings bilaterally. Finally, we're going to go through a few things that can catch you out on brachial plexus MRI, which are normal findings, or common findings which are non-pathological. One of the unfortunate downsides of nerve imaging in general is that patients' nerves are often of variable signal, and they will vary between patients and sometimes between sites and sides of the same patient. A good example of this is that the ulnar nerve at the cubital tunnel may be of large calibre and bright signal in normal asymptomatic patients, and this can be pathological or normal. And in patients with symptoms, this can even be asymmetric. The same thing can happen in the brachial plexus, in which, for example, the upper and middle trunks may be slightly bright on one side, and this can be normal for a patient. Along a similar line is nerve root hyperintensity, which is often seen and associated with foraminal compression in the context of degenerative disease. You can often get this at C8 and T1, even if the roots are not compressed. However, this nerve hyperintensity should never persist into the region of the brachial plexus proper, i.e. into the region of the trunks, and if it does, then this suggests that this is pathological. The images here depict a third problem in which you sometimes get high signal of the nerve because of an accompanying vein in the plexus. This is because slow flow veins retain high signal, especially on some of the longer TE sequences that we use. As you can see in the top left image, there's an apparent C5 root hyperintensity due to a small vessel accompanying the C5 nerve root. And I often use the T1 and STIR sagittal images as troubleshooting for this particular purpose, as if you correlate sagittal images with the coronal image, you can see that the small vessel denoted as a flow void on the T1 image corresponds to the bright signal on the stir. In conclusion, the take-home points are that the brachial plexus imaging relies very heavily on accurate knowledge of the clinical presentation and the clinical question. It's important to note that nerves have a range of normal, which can sometimes be difficult to interpret using a single time point, and I would advise not to get bogged down too much in subtle findings that may not be of clinical consequence, and mainly just to keep in mind the findings that will result in a significant change of management for the patient.